of the GP Smash podcast. My name is Mike. I'm a GP in Sydney, Australia, and I want you to know that nothing you're about to observe constitutes medical advice. This is me studying, and you're welcome to come along and try and learn something with me. That's the idea of this. Now, while I go, I'm going to be creating the podcast, the GP Smash podcast, which is a podcast that I create. Now, you'll be able to see me create that. You'll be able to see how I do that. So without further ado, let's get into it. Okay, I'm going to get straight started. So let's go. Starting with, I'm going to make the intro of this podcast right now. Here we go. And welcome to another episode of the podcast. My name's Mike, and it's very good to have you here with me. Now, today we're going to be talking about things related to ophthalmology. And the reason that is because just yesterday I had a young boy come in, and he had two things going on. One was an upper respiratory tract infection with a runny nose, very common at the moment. And the other was that he had red eyes with some gunky, dried crust on his eyelashes. Now, his father had said they'd went to the chemist a couple days ago, and the chemist had advised them to take Chlorcig, or chloramphenicol, drops into the eye. The chemist had advised them if there was still ongoing issues within, a couple days after starting this treatment, taking those drops every 2 hours, to come and see a doctor. And that's why they came to me. Now, I told them that, most likely this was a viral conjunctivitis based on the fact that he had an upper respiratory tract infection. Both eyes were infected. There was, in fact, dry gunk I could see on the eyelashes. But the kid was otherwise well. No respiratory distress, no rash. He didn't have a sore throat. He was eating and drinking normally, toileting normally. No, abnormal lung sounds. His energy levels were fine. And I advised them to continue on with the chloramphenicol for at least a few more days and to review with us if it was still ongoing by day 7 of treatment. Now, when I looked up the guidelines, what I really found was that I probably did two things wrong here. One was that with a viral conjunctivitis, and you can see I'm getting this information from the therapeutic guidelines here, with a viral conjunctivitis, there really is no role for topical chloramphenicol. And the other thing is that if you were going to use chloramphenicol, it's really 4 times a day, not every 2 hours, particularly if you're going to be using it up to 7 days. So I kind of got those things slightly off, but I don't think it's too bad, pretty close. And they were saying they were having trouble putting the drops in for the kid because he was very sort of non-cooperative. So even though they were trying to put drops in every 2 hours, in reality, it probably was more like properly 4 times a day. Anyway, what I thought we would do is go through the entire thing here of conjunctivitis from the therapeutic guidelines. And then we're also going to learn from this online module that the RACGP has published, this ophthalmology module. Along the way, we're going to try and learn a lot of things. We've got a 2-hour time limit. So it's going to be a long one today, a real long one. And I might break it up into 2 separate podcasts, one on conjunctivitis and then one on ophthalmology, the module. So to start with, conjunctivitis, let's get into it. All right, now, so for those of you studying with me, what I'm going to quickly do here is actually just produce the podcast a little bit. To make the podcast a bit more listenable, I actually put in a few, dribs and drabs of music to just break up the podcast. So hopefully it's a good podcast to listen to, to go over these study notes that we're going to be learning from. Now my computer's probably struggling a little bit at the moment to do that. So what I'll do is probably just because I've got so many different programs all going at once here. So I'll leave that and I'll come back to it. And I'll just continue the recording. I'll just edit the music in later between the few bits of recording that I've got. So let's say I start a new recording around about here. And later on I'll just put a bit of music in here. But for now, let's press play and keep on going. Alright, so here we go, an introduction to conjunctivitis. Conjunctivitis is inflammation of the conjunctiva, and it's a very common clinical presentation. Now, the conjunctiva of the eye is what provides protection and lubrication of the eye through the production of mucus and tears. And here we can see essentially this palpebral conjunctiva, which is sort of the inside of the upper lid. And also there's the bulbar conjunctiva on the inside of the lower lid. And, as we say, it provides protection through the production of mucus and tears. We'll see one more diagram here. And if you're listening to the podcast, the way you can see these diagrams is in the Study With Me sessions, which I do on Twitch. You can study live with me on twitch.tv. Look for the GP Smash podcast. And you can also see these on YouTube after the fact. Here again, we see another issue of what the conjunctiva actually is. It's separate from the sclera. The sclera is the white part, but the conjunctiva is there on the inside of the lids. That would be the bulbar one, and the other one up there was the palpebra, or the palpebral conjunctiva. Okay, so moving on. It's a very common clinical presentation, and there's a number of causes, including viral and bacterial infections and also allergy. Now, the symptoms and signs can help to distinguish between the various etiologies and to avoid, importantly, the unnecessary use of antibiotics, which maybe is something that happened in this case that I explained to you earlier. So let's look at some of the comparative features of the allergic conjunctivitis versus viral conjunctivitis versus bacterial conjunctivitis. Firstly, allergic conjunctivitis, well, that can happen in anyone, children or adults. Whereas viral conjunctivitis is more common in adults and bacterial conjunctivitis is more common in children. So, actually, in the kid that I saw, who was 4 years old, 4-year-old little boy, just based on epidemiology being a child, you would expect it was either bacterial or allergic. It would be less common for it to be a viral conjunctivitis, apparently. Now, in terms of the etiology, local response to allergens, when we're talking about allergic conjunctivitis, those allergens can be, a seasonal allergen that typically flare up in spring or autumn. They could be perennial. I'm not sure what that actually even means. So we'll just have a quick look on Google. What does perennial actually mean, particularly in relation to allergies? Perennial means actually year-round. So these are things that you would have at any time of year, such as house dust, for example. Also, contact hypersensitivity, for example, preservatives in eye drops can also irritate the eye, and that's something to definitely keep in mind. Now, in contrast, if it's a viral conjunctivitis, the etiology is normally something called adenovirus, and that will be obviously therefore frequently associated with a viral upper respiratory tract infection, and perhaps preauricular lymphadenopathy, which is something I didn't check this little boy for. Always got to check the lymph nodes, something that I'm kind of weak on. I sometimes forget to check the lymph nodes. I find them hard to feel a lot of the time, but you've got to check. So that's the viral one, more commonly adenovirus, therefore associated with an upper respiratory tract infection, whereas bacterial conjunctivitis has an etiology that can be primary or secondary. For example, secondary to nasolacrimal duct obstruction, which might be a little bit rare. But the pathogens, if it's bacterial conjunctivitis, would include Staphylococcus aureus or Staph aureus, Streptococcus pneumoniae, or Haemophilus influenzae. And again, these are more common in children. And now we're going to have a look at some of the clinical features that can distinguish between allergic, viral, and bacterial conjunctivitis. For allergic conjunctivitis, one of the things that really is a tip-off is itch. That's common here. Okay, also symptoms are usually bilateral. Okay, itch is common, and also you have a watery or a mucoid discharge. With viral conjunctivitis, you will have conjunctival injection or a red eye. I'm not sure why they call it conjunctival injection and not scleral injection. I'm actually going to put this question to ChatGPT and see what they say. Why do they call red eye conjunctival injection rather than scleral injection. And the reason I'm asking is this because I thought that the conjunctiva were kind of almost glandular type tissue on the inside of the eyelids, and that this is not what becomes red in a red eye. Instead, I thought what becomes red is the sclera. Please explain. And we'll see whether or not we get anything reasonable here. Was the sclera. So what does ChatGPT have to say about this? They say that the term conjunctival injection is indeed commonly used to describe the redness seen in the eyes, particularly in the context of conjunctivitis or other ocular inflammations. While it may seem counterintuitive, as you rightly pointed out, the sclera, which is the white part of the eye, is what we typically perceive as being red. However, the terminology stems from the primary site of inflammation in conditions causing the red eye. So the conjunctiva is a thin, transparent membrane that covers the sclera and lines the inner surface of the eyelids. So it's not just on the inner surface of the eyelids, it actually covers the sclera as well. And it consists of non-keratinized stratified squamous epithelium with goblet cells, which secrete mucus to lubricate the eye and contain numerous blood vessels. Inflammation of this conjunctiva, termed conjunctivitis, can occur due to various causes, as we are learning, and we're learning about the rest of it. So essentially, the summary of that is it's that the conjunctiva is not just in the upper eye and lower eye, it actually covers the sclera as well. Okay, so there we go. That is useful information to know, and that explains why it is that we call it conjunctival injection when we see a red eye. But that's common with a viral conjunctivitis. It's also common with bacterial conjunctivitis. The other thing with bacterial conjunctivitis, it's the only one where you actually have crusting of the eyelids. So actually this kid that had crusting of the eyelids probably had bacterial conjunctivitis. Firstly, he was a kid. Secondly, he had crusting of the eyelids. He certainly had conjunctival injection. And although he had an upper respiratory tract infection, it's not clear whether it was adenovirus or if it was. It's not clear that adenovirus was actually the thing causing the conjunctivitis. The only thing that's also unusual is that in terms of bacterial conjunctivitis, it's usually unilateral, but it can be bilateral. So it can go both ways, but it's usually unilateral. In this case, it was definitely bilateral. Viral conjunctivitis is initially unilateral, but it often becomes bilateral. All right, so that's basically an overview of these things. Now, when would you refer to an ophthalmologist? A referral to an ophthalmologist is required for conjunctivitis if it's associated with severe or worsening symptoms, for example, significant pain or reduced vision or photophobia. And that's to exclude a more serious diagnosis, such as keratitis. Now, we're not going to be actually going into the details of keratitis here, but just so that we have some sort of an understanding of it, let's get a quick overview here. So keratitis refers to inflammation of the cornea. That's what it refers to. The cornea being the clear, domed-shaped surface that covers the front of the eye. Let's get a look at this. The cornea. It's the domed-shaped surface that covers the surface of the eye. It's transparent, and in effect, you have the sclera here and the cornea here. So how do we know which one is the most outer? What is more outer? What is the outermost layer of the eye? The sclera, the cornea, or the conjunctiva? There's a question. That's going to be important to know. The outermost layer is the cornea. It's a transparent dome-like structure. It's located at the very front of the eye, covers the iris, the pupil of the anterior chamber, and has a protective barrier against foreign particles. The sclera is the tough white outer layer that forms the white of the eye, and the conjunctiva is the thin transparent membrane that lines the inner surface of the eyelids, again the palpebral conjunctiva, and also covers the sclera, which is the bulbar conjunctiva. and lubricates the eye. Okay, there we go. There we have it. That helps us a little bit. Now, moving back to understanding a little bit more about keratitis, which is inflammation of the cornea. Why is that actually so serious? Well, the reason it's considered serious is because it can threaten your vision. Inflammation of the cornea can lead to significant vision impairment or even vision loss if it's not promptly and effectively treated. And that's because it can cause scarring of the cornea, and that can permanently cause visual impairment because it disrupts the normal transparency and refractive properties of the cornea. Now, this is very helpful to know. It doesn't matter that it's coming from ChatGPT. It's extremely helpful to know. Okay, now if it's untreated, you can get corneal ulcers. Certainly we've heard of those things. Even leading to perforation of the cornea. That can risk intraocular infections, which is what's known as endophthalmitis. It's actually intraocular. And potentially loss of the eye itself, not just vision, but loss of the eye itself. So that's in severe cases of keratitis. Okay. It can also cause a lot of pain, and that's another reason to treat it. It can also spread systemically. And this is the reason why you really need to, in these cases, where you have got what you think is conjunctivitis, but it's associated with significant pain, reduced vision, photophobia, you need to get them to an ophthalmologist to have proper assessment to make sure it's not keratitis of some kind. Now, children aged 2 to 12 months with sticky eyes often have a blocked lacrimal duct rather than conjunctivitis. Now, this kid was 4 years, so he's older than that, but this is for the infants. You have to say that they commonly have a blocked lacrimal duct, and that actually the accumulated material is mucus from the tear film rather than pus. So if the conjunctiva is not inflamed, you should treat it as if it was something called epiphora. All right, so what is epiphora? It's the medical term for having watery eyes. Okay, and how do you treat that? Well, maybe we'll get into that later on. Let's stick to conjunctivitis, and that way we'll make a bit more progress. Okay, so essentially now we've gone through some of the comparisons between allergic, viral, and bacterial conjunctivitis. And we're going to have a look at a couple other ones, including chlamydial conjunctivitis and gonococcal conjunctivitis, when we come back from this short break. Thank you for watching along and listening to the podcast, and we'll see you very soon. Cheers. All right. Again, like I say, I'll come back and I'll put some music in here, make this a bit more listenable later on. In the meantime, let's carry on essentially going through a bit more depth of this conjunctivitis session. I hope this is this is useful for you. If you're finding this useful, please do let me know in the chat. Okay, now let's make this happen again. Thank you for sticking around, guys. Let's keep on going. Let's go into a little bit more depth now about allergic conjunctivitis. Now, one of the most common causes of non-infective conjunctivitis is, as we've learned, allergic conjunctivitis, and it results from exposure to an allergen, which can be seasonal, like in spring or autumn, or it can be perennial throughout the year, like dust mites or dust in the house. It can also be from contact to an allergen, like preservatives in eye drops, for example. And the primary diagnostic symptom, as we've went through before, is itch with watery eyes. It's not about gunk and crust on the eyelashes. It's watery eyes with itch. Okay. Now, with seasonal and perennial conjunctivitis, symptoms are usually bilateral. And for the treatment of allergic conjunctivitis, well, that's actually something that we'd very much like to know. So why don't we take a look at that? Again, if they are having severe pain, worsening pain, visual disturbances, you need to get them to an ophthalmologist again to have them assessed for whether or not this is actually keratitis or inflammation of the cornea, which, as we know, can lead to ulceration of the cornea, infections even intraocular like endophthalmitis, things that we just don't want to have happen. So we've clicked on the link here in Therapeutic Guidelines to get some more information on the treatment of allergic conjunctivitis, and it's just brought us back to the exact same page we were already on that actually hasn't given us any information at all about the treatment of conjunctivitis. So let's just go back to where we were, and we'll continue on learning a bit more about the viral conjunctivitis and bacterial conjunctivitis. Just pausing the recording because this is all happening very slowly here. Stream is obviously still ongoing. Hope you guys are learning something here. Really hope you're learning something. All right, so moving on with viral conjunctivitis. As we've also mentioned, it's most commonly caused by adenovirus and is associated with an upper respiratory tract infection and preauricular lymphadenopathy. So diagnosis is clinical. You don't take a swab or anything. You don't test. It's just clinical. And the symptoms are you will have a red eye, but it'll be a watery discharge. It won't be itchy. The irritation is initially unilateral, but often becomes bilateral. Okay, so symptomatic treatment is recommended, and it includes cold compresses several times a day and lubricant eye drops. Okay, there's not really any role for steroids, at least not without the advice of an ophthalmologist. And there's also no role for chloramphenicol in this case. Okay, now ocular infection with herpes simplex virus, and for that, you can think it's a type of keratitis, and herpes zoster virus, which can cause herpes zoster ophthalmicus. Now, these are things we might learn more about in the next session. We're going to be going through a bunch of ophthalmology things, so we'll come back to these next time. But basically, ocular infection with these particular viruses can cause conjunctivitis, and in those cases, you also want to involve an ophthalmologist. Again, particularly if they've got severe pain or it's worsening, there's reduced vision or photophobia, you need to get them seen in that case. Again, bacterial conjunctivitis can be primary or secondary, for example, due to obstruction of the nasolacrimal duct, which as we know now is most common in infants 2 to 12 months of age. But if it's just a primary infection, it's typically present with conjunctival injection, which is red eye, purulent discharge, and crusting of the eyelids. Common pathogens are Staph aureus, Streptococcus pneumonia, and Haemophilus influenzae, particularly in kids less than 5 and who are not fully vaccinated, which often causes conjunctivitis otitis syndrome. So that is what it sounds like, both eye and ear inflammation. Now we're going to get a bit more information on chlamydial conjunctivitis and gonococcal conjunctivitis a little bit later. Okay. There's also conjunctivitis caused by Neisseria meningitidis, which can precede or accompany systemic disease, and treatment is as for invasive meningococcal disease, which is something we'll look at another time. Okay, but many cases of bacterial conjunctivitis resolve within 7 days without treatment. What does that tell you? It tells you that chloramphenicol is probably not even necessary a lot of the time. But that's, some of the time it still will be necessary. So, there we go. Systematic reviews have found that topical antibiotics do confer modest benefits in improving symptom resolution in bacterial conjunctivitis, but most cases resolve in 7 days without treatment. Now, that's not something I was aware of, and I wish I had known, because I would have probably advised this parent differently. Instead of continuing on with the drops every 2 hours for the next few days, I would have said, look, keep going with the drops, but pull it back, only do it 4 times a day. And, if you can't get it in at one point because you're distressing him a lot, don't worry about it. It's probably what I would have said. Okay, now in patients who have marked symptoms like purulent discharge, well, then it is reasonable to prescribe chloramphenicol. And this kid did have crusting on the eyelids, and all neonates and young infants do require treatment, just in case. And as we know, it's chloramphenicol, 1 drop into the affected eye 4 times a day. That's all there really is to it. You can use phromycetin. That's a good thing to know, but why would you? Maybe if they've had a bad reaction to chloramphenicol in the past. But phromycetin, something to keep maybe in the very back of your mind. Now, both chloramphenicol and phromycetin can cause hypersensitivity reactions, which may be severe and also may make things look worse. Okay, so basically aminoglycoside and quinolone drops are not recommended for empirical treatment. Okay, if you're going to treat, it's with chloramphenicol first line. Once again, if they do have photophobia, severe pain, worsening pain, vision loss, straight to an ophthalmologist for exclusion and or treatment of keratitis. Now, before we finish up here today, we're going to have a look at chlamydial conjunctivitis and gonococcal conjunctivitis. All right, starting with chlamydial conjunctivitis, which basically is a form of conjunctivitis, and it presents normally as an acute or a subacute unilateral conjunctivitis with mucopurulent discharge, or as a chronic conjunctivitis. Now, it should be considered as a differential diagnosis, of bacterial or viral conjunctivitis. Well, I guess technically it is a bacterial conjunctivitis, isn't it? Chlamydia trachomatis being a bacteria. Now, it actually usually occurs in neonates and also in adults with exposure to STIs. Infection in a neonate or infant or child may reflect mother-to-child transmission, accidental transmission, or even sexual abuse. Something we really don't even want to think about, but unfortunately it's a part of life. Conjunctival swabs for nucleic acid amplification testing are recommended in all neonates and in patients with persistent conjunctivitis when chlamydia trachomatis is suspected. So again, diagnosis is normally clinical. You don't have to do any tests unless you're suspecting chlamydia trachomatis, which you might in a kid, an infant, a neonate particularly, and particularly maybe if their parent has got a unilateral or chronic conjunctivitis, definitely something to think about. In that case, it's actually systemic treatment that's necessary. You don't use topical therapy. You actually just go, for anyone over a month old, you use azithromycin. For the kids, it's 20 milligrams a kilogram, up to a gram daily. It's a single dose. For neonates, it's azithromycin, 20 milligrams per kilogram daily for 3 days. So actually a bit more intense. And about half of the neonates that have chlamydial conjunctivitis, they will have an associated chlamydial pneumonia, atypical pneumonia. So treat the mother of the infected neonate, and the approach to chlamydia infections, it can be seen elsewhere. And again, if you think that they have severe pain, photophobia, reduced vision, you know the drill by now. Send them off to ophthalmology because they may have keratitis. Now there's also something called trachoma, which is a form of chronic conjunctivitis caused by chlamydia trachomatis. And actually it's caused by repeat infections with serotypes A, B, B'a or C. And it's the leading cause of preventable infectious blindness in the world, especially in developing countries, which Australia is not. But it is still common in remote Aboriginal and Torres Strait Islander communities in Australia, so that's very important to note. That conjunctivitis in remote Australian, Torres Strait Islander, Aboriginal communities can certainly be an indication for systemic treatment with azithromycin and perhaps a swab, particularly in a neonate, because it might actually be a chlamydial infection. They might be associated with a chlamydial pneumonia infection and definitely needs treatment because it is a leading cause of preventable infectious blindness called trachoma. All right, and without treatment, recurrent infection leads to scarring of the eyelids, corneal ulceration, corneal scarring, loss of vision. And you have to suspect it in all cases of conjunctivitis that come from those endemic areas. Super important stuff. Now, in areas where it's prevalent, you have to also encourage regular face washing, and treatment of household contacts is also recommended. So if someone's present and they end up having a chlamydial or trachoma, you got to treat the family members as well, or household contacts. Not only that, but community-wide treatment might also be indicated if the prevalence is very high. So that's chlamydial conjunctivitis. And finally, to finish off today's podcast, but not necessarily to finish off today's study session, but to finish today's podcast, let's have a look at gonococcal conjunctivitis. This is a conjunctivitis caused by Neisseria gonorrhea, and it usually presents acutely with copious purulent discharge. In that case, you do want to get a culture and a gram stain nucleic acid amplification testing on the conjunctival swabs will confirm the diagnosis. In this case as well, it is in fact itself an ophthalmic emergency. So it's not just a matter of thinking that it might be keratitis. And the reason is because gonococcal conjunctivitis itself can cause ulceration and perforation of the cornea. And so itself is an ophthalmic emergency. So get the ophthalmologist involved. Now, why would you suspect gonococcal conjunctivitis? Well, that's a really good question. And I guess, again, it comes down to the acute onset of copious purulent discharge. Okay. And what you essentially do if you are suspecting this is you start empiric treatment immediately. Okay. And the empiric treatment is pretty much going to be ceftriaxone or cefixime with azithromycin. But you're going to start with ceftriaxone. And again, this is intramuscularly. Okay. Similar to how you would treat a gonorrhea sexually transmitted infection, treating it the same way. IM ceftriaxone. Again, infection in neonate or infant or child may reflect mother-to-child transmission, or maybe, could even be sexual abuse once again. All right, now, azithromycin is used concomitantly with ceftriaxone, and that's to delay the resistance that's developed and developing from gonorrhea in relation to cephalosporins, because co-infection with chlamydia is also possible as well. So it's in fact ceftriaxone and azithromycin, or cefotaxime and azithromycin. Either way, it's one plus the other. So it's actually ceftriaxone IM plus azithromycin. Now, in neonates, it's essentially the same. What else do we need to know? We need to know that normally it presents in the first 2 to 5 days of life, sometimes even at birth, with a hyperpurulent conjunctivitis, which is highly contagious and can rapidly lead to perforation of the cornea and blindness. So you need to get that testing done on a conjunctival swab. Okay, you request a culture with a gram stain and nucleic acid amplification testing, and you start empiric treatment, which is not topical therapy. It's systemic intramuscular cefotaxime or ceftriaxone plus azithromycin. Okay, that's just how it's done. The cefotaxime or ceftriaxone will be a single dose, but the azithromycin will go on for 3 days. Again, you give the azithromycin in addition to the ceftriaxone to make it harder for the antibiotic for the bacteria to become resistant to the antibiotics, and also because there's often co-infection with chlamydia. The other thing you can do is irrigate the eye with saline several times until the purulence subsides. Again, if you're suspecting this copious purulence from the eye, straight to an ophthalmologist. You don't need to have the severe pain and the vision changes and the photophobia and the bad headaches that would normally trigger you to think about a keratitis and ophthalmological referral if they've got copious output of mucopurulent discharge, particularly if it's a neonate in the first few days of life, or even if it's not, even if it's someone particularly from an endemic area. Straight away you get them to an ophthalmologist. Again, if they're neonatal, you've got to treat the mother as well, and you might even need to treat other contacts. With all that said, that is an overview of conjunctivitis. I hope you found this helpful. Once again, if you want to study along with me, you can go to twitch.tv and search for the GP Smash podcast, and you'll find me there studying away on a regular schedule. Your questions there are always welcome live. You can study along with me, and keep your eyes peeled for some more podcasts coming soon, particularly the next episode in which we're going to be looking through the ophthalmology module that's been published by the RACGP. Until then, I'm Mike. Thanks for listening to the GP Smash podcast. Once again, if you want to get in touch with me and you don't want to go through Twitch, you can just email me at gpsmashpodcast.com. I'll be happy to hear from you. gpsmashpodcast@gmail.com. Be happy to hear from you. And again, thanks for hanging out with me and learning something. We'll see you again next time. Bye-bye. Alrighty, so there we go. That's essentially a first episode here done. All right. Now, I would again love to get some of this. Here we go. Now we've got some music happening, so I can finish off this recording. I'm going to just zoom in over here, if I could. Where are we? Here we go. Zoom in on this spot, and let's put nice electric piano. We'll just loop that around a bit. All right, the other thing I want to do here is be able to alter the volume. I don't know why that's so low. That should be a bit higher. Okay. I'm going to bring this volume right down and let this fade in. And I'm going to let this fade out. All right. And in effect, I'm going to do that same thing over here where we took another little break. Here we are. Let's use this one this time. We'll loop this a few times. If it will be so kind as to allow us. Alright, what I'll do is just copy and paste it. There we go. And once again, I'm just going to let this fade in. And also fade out. Okay, and I think that was the last break I took. So now I can just basically put a bit of outro music, which I need to actually make. Okay, I'm just going to take it from here, copy that, bring that over to here, end of the podcast episode, paste. Don't copy that, that's fine. Alright, and what I'm going to do now is send this out. So I'm ready to share the track. How can I do that now? I've never used this actually before. I used to use GarageBand. File. I'm ready to export or bounce. Export all tracks as audio files. Share. There we go. Share song. I actually want to share it to somewhere else. Export. Export. How can I do this? Share. Project GarageBand. Yeah. Yeah, Nani. No thanks, Nani. No thanks. Okay. And this one was about conjunctivitis. But it's not really how I want to do it. I want to share this. Just as a file. Export selection as an audio file. That should be good. All right. Come on, why is this so hard? Should be easy. Bounce project, how about that? Destination MP3. Requires 736 megabytes. Come on, dude. This is crazy. This is really frustrating, actually. Save as. Alright, I'm going to share it to music and then see if I can just find it from there. Okay, so it's bouncing. Sorry that took so long. Is anyone watching at the moment? Nope, that's fine. So again, if you have been watching, keep in mind that, you'd be very welcome to check out the podcast that I've been creating. Now, that podcast is available on Spotify. It's available on Apple Podcasts. It's called GP Smash, or GP Smash Podcast. And you can see there's already a number of episodes up. And I'm putting more up all the time at this point. And I will be for at least the next 9 months or so. Probably keep on going, depending on how we go. But, we've got a few episodes up there already. Hopefully it's going to be very helpful. Certainly for myself, and hopefully for some of you guys as well. Okay, in the meantime, are we ready to go? This is still exporting. So what I'll actually do is I'll stop this stream and we'll come back for the next stream shortly. All right, thank you for watching, and we'll see you soon.